video was originally recorded during the PalTrace webinar on July 21st, 2021. In it, Vicky Opia, a palliative care nurse specialist in Uganda, discusses her experiences integrating palliative care into a prolonged humanitarian crisis.
Thank you so much, Dr. Moira, for introducing me and giving elaborate things about me. Today, I'm delighted to speak in the PalTrace meeting webinar on integrating palliative care into a prolonged humanitarian crisis. As mentioned, I'm Vicky. I'm a palliative care nurse specialist based in Uganda and Germany in particular. Next. I'm going to talk about key things. I've outlined my discussions. I'm going to talk about population of the refugees in Uganda and Germany, and also the needs of the host and refugee population, and how we integrated palliative care into humanitarian settings. What is the impact and the key lessons learned after our integration? What is the population of refugee in Uganda? Well known that Uganda is one of the countries in Africa. I believe it's the first that hosts the largest refugees worldwide, particularly in Africa. We have over 1 million refugees in Uganda, and mainly they come from South Sudan and DRC, Congo. And 85% of these refugees are women and children. In the map, you can see some of the brown highlighted districts. All those districts host refugees. What are the needs of the refugees in humanitarian crisis or during emergencies? Just like me and you, we need a lot of things for us to live. We need shelter. And when they came, quickly interventions was made to have them sheltered. And also there's that need of food, and food was provided for the refugees. There was need for health, and health centers were restructured for them to care for the health-related issues. And also sanitation was constructed to them. What is it like? What is life like for the refugees? Both for the host and the refugees. In Uganda, I want to say we are so special, and many times we believe we are the modern country that hosts refugees in a different way. Because the structure that you see there is the same structure that our host community live in. There have been constructed structures that they stay within the community, they stay with us. We share the health centers together, we share borehole together, we share schools and even marketplaces together. The little boys and girls are jubilating because the borehole that gets safe water is the same water that we drink and the same water that the refugees drink. They live in small structures that their grandchildren, the health workers come to visit them while they are in the structures. And that is the beauty. The marketplace, they have got some small stalls where they sell things to earn their living. The same market is the same market that the host and then the refugees use. And that is the model of the kind of refugee that we host in Germany and Uganda as a whole. One may be asking, then, what is life like in the face of chronic illnesses? It is challenging. Yeah? I want to illustrate it using these two different persons. One is a refugee, and then one is a host community. We visited this young lady. She's 19 years with a little girl besides her. She was diagnosed with adenosarcoma, and she was supposed to be referred to Mulago. Mulago is one of our national referral hospitals where Cancer Institute has been instituted. She needed some funds to reach where Mulago is. And of course, in our community, men are the brain winners, and therefore they are the decision makers. A meeting was deliberately organized such that this lady could get some funds so that she can access medical services like chemo and radiotherapy. Very unfortunately, she has a man who drinks a lot. That day he was drunk, and therefore the meeting did not take place, and she did not go to access medication. She died without having the medication. But the other physical, psychological, spiritual care was taken over by a team of palliative care in a Germany district and as peace hospice. And the lady also you see me smiling with is a lady who had liver cirrhosis, and she's a refugee. She's an S teacher. She had her children besides her, but we got her during a ward round. She has a huge liver cirrhosis with edema of the lower limb. Then we discuss with her, we assess her, and all the other intervention was given to her while she was in the hospital. She improved, and we discharged her at home. We made a follow-up after like a month or two. We got when she was okay, she was full of smiles, she was happy. And that was the time Dr. Moira visited us, and we got an opportunity of visiting her together with this lady. Of course, we discussed about her life, and she told us she felt young again. And she felt like she was 15 and ready to remarry if there was an opportunity to remarry. That was a miracle for us because we felt we did what we could for both the hosts amidst challenges and the refugees amidst all these challenges. And next, we realized there is a gap, just as I was saying. You can't live without a gap as you're providing services. We interviewed around 108 persons who live with chronic illnesses. What did we realize? We realized that there was a huge and significant unmet need with these people. And also there were a high symptom burden as reflected on the percentage that you can see, that 67% of those we interviewed reported with pain score between 4 to 5. And also only 7% of them had access to oral liquid morphine that could control their pain. That was how bad it is when you come to palliative care with a humanitarian setting. But we used several interventions to help bridge this gap. What did we do? We went, next slide, we went into community sensitization. We get down to them, we get their views, and together we realize that this is a challenge, and we get to bridging the challenges. What can we do ourselves? And we did this in many settlements. Those are community leaders within the refugee settlement. We discuss with them and they chart the way forward. And also we go on radio talk shows. We get to radios because the radio is well heard. The population, even the other district, not only Ajumani, Moyo or Bonyi, listen to the same radio. So when we go to radio talk show, we realize many people ask questions. They give in solution to issues raised, and we do a lot of things. And then also, we didn't only stop there. We had to indulge into trainings. We trained, next slide, sorry. We train, we get into engaging leaders. They are political leaders within our community. They are opinion leaders within our community. We get into meetings with them. We have our prominent political leader who is the MP, and at the same time sits with us in Peace Hospice. We went to their district and we talked about palliative care, how important palliative care is. Have you realized it? They say it's a God-given gift. Our presence there means that God's love has come into the community. And they also go on, I want to say it's like a promise. They pledge support and they say, the intervention you bring to us will live because we know it has come to improve the quality of life of our people. And it is very important when people speak from their heart. We also do a lot of trainings, both for the healthcare givers. We do trainings in the hospitals. We do trainings in the community. Next slide, please. Yeah, as I said, we do a lot of trainings in the hospitals, a lot of trainings in the health facilities. And we train what is called link nurses. These people link those with palliative care needs to the specialist care. And they also do what they can before they link them to the specialist. I was trained as a specialist palliative care nurse with a bachelor's degree in palliative care. I also did a nurse leadership course that helped me to enable others be able to solve problems. And also because of this many intervention, we now have a lot of access of medication in our facility, particularly oral liquid morphine. And the referral pathway is being used to link our patients, because we have the district health hospital, we have the health center 4, the health center 1, the health center 2 and the health center 3 is linked to the hospitals. And people say out, like for example, this one said, I've been doing things when I've not been trained. And now that I've got the palliative care training, I can adequately assess patients' pain and link them to areas where they're supposed to receive their care. And to us, that is so, so powerful. Next slide. We've trained what we called community health workers. For us, we call them VHT. These are people who live within the community. They know their people very well, and they're being selected by the people to be trained as community volunteers. There are short courses that they demand for themselves. They ask for mentorship, they ask for research. And when we train them, at times they give us some quotes from their heart that we realize this training is a key aspect of life that has been missing in the community. And today it is acting as an eye-opener. It is touching our heart. Therefore, we'll do fabulous things. We'll do our best to link our people for care so that when they're leaving this earth, they leave the earth painless. And somebody says, this is one of the most important and long awaited for a training. I did not know that this palliative care, but now I know it. Therefore, I am transformed and I'll transform the community. So these are some of the quotes that we get when we go on doing trainings on palliative care. We have, next slide, we have a very young person who is a refugee. Philip was trained as a community volunteer, as a village health team. And he says, when I moved to the community, I do a lot of counseling, I do a lot of spiritual care, and I mentor others, I teach others. It is coming from his heart. Today, he's identifying a lot of people. And as I talk, they're organizing already what we call a community outreach. They're organizing the people with the chronic illnesses, and we get down to them and we assess them while in the refugee settlement. And while doing so, the health workers who have not even got this training will be mentored and thereafter be able to do this, offer the care even when we are not there. The next slide is going to show to you one of our own. He is from the host community. Well, when he got the palliative care training, he went on identifying people in the community. And while identifying people in the community, he gained a lot of popularity. After gaining popularity, he stood as a mayor in his community. And he won with 80%. And he's saying he's attributing that to the knowledge that he got during palliative care. That did not come from himself, but the knowledge made him to be able to gain popularity. And now he's the LC3 of his community, a mayor in his community. The next slide. The next slide is going to show to you the intervention we made for caregivers. We have been training caregivers. Caregivers is not only this person who will be by the bedside of the patient. Even a neighbor can be a caregiver in our community because we live together. The neighbor also cares for the neighbor. Therefore, we trained them, and some of them kept on reflecting on how bad they have been caring for their people, because they do not know that these people matter, and they matter until the end of their life. They are now saying, we need to apologize to our own people. We need to talk to our own people. We can now care for them in the way that will help them until when they leave us with happiness. The next slide is going to show to you what we do when we are in the community. We offer holistic care, high quality care. We are so compassionate. We offer clinical care both in the hospital, in the facilities, and in the home. The person smiling is smiling with the patient, and the patient is also smiling. This patient has advanced cancer of the cervix. But as you're aware in the practice, that when pain is totally gone, we bring smile to the face of our people. That is how beautiful it is to offer palliative care in the humanitarian setting. There's a lot of impact in what we are doing. What are some of the key impact that we got after intervention of integrating palliative care into humanitarian setting? In 2019, 2021, the work plan of the district has palliative care embedded in it. And then the district hospital or health center 4s now provide palliative care. The staff in health center 3s are able to manage simple pain of the patient and only refer those complex issues to the hospital and peace hospice. And also the VHTs are able to appropriately identify cases and link them to care. Availability of morphine for pain is there. And also the humanitarian implementers are now including palliative care. That is why we're working hand in hand with Medical Teams International. Philip works for Medical Teams International, and some of the staff, after training, we now work together with them. And also we have a focal person who is involved into the meetings of the clusters. And also we have scale up palliative care to other districts. What are the key lessons learned when we did all this intervention? Be ready for the long haul. And also we involve wide range of stakeholders. Ensure we have ensured using different approaches to integrate palliative care into a humanitarian setting. And we are also saying, inspire others, involve others. What I do inspire others. That's why the people we have offered palliative care to in terms of training come up and then do what is needed. Offer quality, high palliative care that is so component. Don't give up. I just want to pause and talk about that picture. That picture shows ladies who don't give up, just like the way I don't give up. Everything matters in our life. That's why she's even carrying the goat, despite the fact that she has a baby in her hand with all that luggages on her head. That district is totally blocked with a flood, and even the water hyacinth has covered the water. But we struggle to penetrate and go where they are because we want to offer them support. I want to thank our donors. I want to thank our partners for supporting this kind of humanitarian setting, the hard to reach areas. Thank you so much for involving me to speak out what had not spoken for long. Thank you so much.